Good afternoon. So I'm Jesse Roman. I'm the chair of the Department of Medicine, and I'm also a pulmonary critical care guy who's been interested in interstitial lung disease for a number of years now. Your group asked me to talk to you about interstitial lung diseases, and that's an area of interest to me because throughout my career and the people I've met in my training were very interested in how the lung repairs. Now think about it. You take a breath every number of seconds. Your lung is exposed to the environment you're surrounded by. You inhale dust particles, you inhale infectious agents, you inhale potential injurious agents, and yet throughout your life, for most of you, the lung will be able to manage that, and if it's injured, it's able to recover to normal function. But in few people, depending on the injurious agent, depending on the timing, depending on the intensity, depending on host factors, that will not happen. And what we'll see is a process of what people call disrepair. As opposed to repair and normal wound healing, it will be disrepair, causing chronic inflammation, exuberant fibrogenesis and scar formation, destruction of tissue, and loss of lung function. When that happens in a syndrome that I'm going to present to you in a minute, that qualifies for interstitial lung disease. Now, I could talk to you about interstitial lung disease, but as you see in the title of the slide, I'm going to focus only on a subgroup of interstitial lung disorders. Why? Because there are close to 300 interstitial distinct lung disorders. There's no way I can do justice to each one of them if we tackle them in a single session. So I'm going to deal with a subgroup of interstitial lung diseases that has become very important because of its better understanding about it. New drugs that seem to might be beneficial in some of these patients. And number three, because they're relatively common, more common than what you think. So let's get started. These are my disclosures, which apparently are not showing appropriately well here, but I do a lot of clinical trials, so I receive dollars to engage in research and clinical trials. I'm not part of any speaker bureaus, and I do research also funded by the NIH and the Department of Veterans Affairs. Here are the learning objectives. We're going to talk about interstitial lung diseases in general, so you get a good sense about that. In general, we're going to talk about evaluation and management of ILDs. Then we're going to focus on the idiopathic interstitial pneumonias, that subgroup that I told you that is becoming quite interesting. And we're going to summarize the clinical presentation and management of idiopathic pulmonary fibrosis, which has become sort of the prototype of these idiopathic interstitial pneumonias. And at the end, we're going to just give you a few examples of cases that might be of interest to you. I'd like to start with the definition of Marvin Schwartz. And Marvin Schwartz is one of the editors of the textbook of interstitial lung disease. And he states that interstitial lung diseases comprise a diverse group of lung infiltrations that cause disruption of alveolar structures and have in common clinical, radiographic, and physiological consequences. I have trouble with this definition because it's a definition that really doesn't emphasize anything in particular. And you really can't define a patient with interstitial lung disease by just looking at the definition. But what this definition does, and you'll see that highlight throughout my presentation, is that it emphasizes that you need all the above to reach the appropriate diagnosis. There's no single clinical presentation, imaging findings, or histological findings that can help you or define a particular diagnosis. You need all of them many times to come up to that answer, and I'll describe that a little later. Now, I mentioned to you how the lung is able to repair. Look at the lung structure is incredibly delicate. Okay? These are microns sections, and you have to have a very thin alveolar membrane so the gases can exchange. Once that interstitium is full of water, infectious agent, malignant cells, fibroblasts, connective tissue, you start thickening or enlarging that alveolar capillary membrane so the gas exchange cannot happen. Well, that's what happens in interstitial lung disease. There's tremendous amount of inflammation and connective tissue deposition and fibroblast accumulation in the interstitium of the lung, and therefore that is called chronic or interstitial lung disease. And so that's the general presentation of many of these disorders, but they all react and present in a different way due to different causes. So I want to start with this case. This is a 66-year-old man who was a musician who I met in Atlanta some years ago, who came to us after being seen by his doctor for a number of years. He was already on steroids for lung fibrosis. As you can see here, he had dry cough, dyspnea on exertion. Physical exam showed bibasilar crackles. He had clubbing in his fingers, which is not that common, but he did have that. And his lung physiology showed a restrictive defect as, a mild obstructive defect, a severe obstructive defect, as presented by a normal ratio but decreased FE1. He was a smoker. He also desaturated when he walked. And he had, as you can see here in the x-rays, bilateral infiltrates. So the question is, what does this patient have? Well, we know he has interstitial lung disease because he has what we call the syndrome of ILD. What is that? It's these four characteristics: shortness of breath, bilateral infiltrates, not unilateral, not unifocal, bilateral infiltrates on imaging studies, physiological abnormalities, as you saw by pulmonary function tests, including desaturation. And he had inflammation of fibrosis on histology, which I did not present, but it was pretty obvious when you look at that imaging. I would add another part of this syndrome, and that is chronic presentation. It is rare to see a patient with interstitial lung disease who presents only for that disorder and the symptoms only appear that day. These people have been suffering from these symptoms for a number of weeks to months and even years. So as I told you before, the world of interstitial disease is loaded with a lot of conditions. For example, the granulomatous diseases, a classic example is sarcoidosis. The collagen vascular disorders, rheumatoid lung, is an example that everybody would be familiar with. Inhalational causes, such as asbestos-induced fibrosis, in the case of asbestosis. Drug-induced, in the setting of amiodarone or nitrofurantoin used for a number of years for chronic urinary infections. Specific syndromes, such as eosinophilic granuloma or lymphangioliomyomatosis, which we're going to learn at another time. We're going to talk more time about the idiopathic interstitial pneumonias, and of course inherited causes, such as people who have a specific genetic disorder that is associated with a fibrotic disorder, and you're going to see an example of that today. How common are interstitial lung diseases? Well, people usually are used to seeing patients who are smokers, who have shortness of breath, and if you make a diagnosis of COPD or asthma, you're probably going to be right many times because there are millions of patients with that condition. This condition is not common, but it's not that uncommon. So there are about 100,000 hospitalizations yearly on this condition, which is probably an underestimation. About 15% of patients seen by pulmonologists have interstitial lung disease. If you look at specific entities, you'll see higher frequency of this condition. In scleroderma, many people say that if you wait long enough and you look carefully enough for imaging studies and physiology, you'll find in almost 100% of cases, you'll find some interstitial distortion. 33% of patients with rheumatoid arthritis may have this. And idiopathic pulmonary fibrosis affects about 180 to 200,000 patients a year. Again, compared to the COPD patients and the asthma patients, these are very few. And yet they're very important because many of these conditions are idiopathic, difficult to diagnose, we don't have great treatment for them, and they're deadly. Now, the general evaluation when you encounter a patient with interstitial lung disease are simple. First of all, a history of physical exam. Like any other condition, history of physical exam are crucial. And a lot of the information you're going to obtain to decide what condition the patient has is very much based on the history and physical exam. You need imaging studies. We cannot evaluate carefully interstitial lung disorders without having a good high-resolution CT scan. It's become that important to us. Physiological tests, pulmonary function tests to evaluate obstruction, restriction, intensity of the impairment. 6-minute walk test, which is a way to evaluate for saturation or ability of the person to engage in exercise. In many cases, you're going to need tissue sampling so that you can determine what is in that tissue that is causing the condition. And in other cases, you're going to need serologies. For example, if a patient may have arthritis and you think they have rheumatoid arthritis, you may need some serologies to confirm that diagnosis to associate that with the interstitial process that you're being evaluated. I want to step aside a little bit to talk about the pulmonary function test and restriction, because many people equate restriction to interstitial or fibrotic lung disease. That is not the case. There are 3 major physiological disturbances that can cause restriction on pulmonary function tests: chest wall abnormalities, morbid obesity, trauma, flailed chest, ribs because of fracture of ribs, Neuromuscular disorders, myasthenia gravis. If you don't have the ability to expand your lung, it will be detected as a restrictive disorder, even though the lung may be normal. And of course, lung diseases. But even here, you might even miss patients with mild congestive heart failure, which the water will be accumulated in the interstitium and show restriction, when in fact the problem is not primarily in the heart, in the lung, it's actually in the heart. So a restrictive defect does not equate fibrotic or interstitial lung disease. The second point I want to make is that compliance is important, and it sort of explains why these people are short of breath. In a normal patient, you need a certain amount of pressure to obtain a certain amount of volume. That's how you inhale, get about 400, 500 cc's of air, and then you release it. In emphysema, you need very little pressure because the alveolar septa had been disrupted. That's where the elastic recoil is. And so you need very little pressure to reach the same amount of volume. In fibrotic and interstitial lung disorders, you need more pressure because there's more collagen and matrix deposition in the interstitium. So that lung is more rigid, and it takes more effort to expand it. So these patients, as their disease progresses, can decrease their volumes and increase their rate in exchange of decreasing their dyspnea and their effort. I mentioned to you that CT scans are crucial, and they're crucial because they allow you to get a sense of the extent of the damage, but they also allow you to evaluate the distribution pattern. And patterns have been very important for us to begin to distinguish one idiopathic interstitial disease from another. We can look at a CT scan or another imaging study and kind of come closer to the diagnosis. So having a good HRCT is crucial. How about the general treatment of these conditions? Now, of course, it depends on which condition you're dealing with, but in general, there's a lot that we can do to educate patients. We can decide very early on if they need oxygen or not, independent of their distinct condition. We can determine if rehabilitation can be helpful. We can treat comorbidities such as heart disease or other problems, infection. We can deal with preventive care issues such as vaccinations, for example. We can evaluate for cancer. People with interstitial disease, particularly idiopathic pulmonary fibrosis, have a higher incidence of cancer. Many of them are smokers, so that's important. Or you can engage in the direct management of condition through immunosuppressive agents. There are newer drugs now that are considered antifibrotic. If there's no good drugs or you're trying to identify other things that might be helpful, you can engage the patient in clinical trials. Or you can ultimately end up requiring lung transplantation. So you can put a new lung in the patient. So there's a lot of options for these patients, but as you can see, there's a lot more that are needed. So we've talked about the interstitial diseases. We've talked about the evaluation and management in general. Let's talk about the IIPs, the idiopathic interstitial pneumonias. And we're going to follow that by talking about IPF because the history of understanding the IIPs is very much linked to the understanding of IPF. So I'm going to need to describe to you how we arrived to this diagnosis of IPF for you to understand what are these idiopathic interstitial pneumonias. So again, the world of ILD, there's a subgroup called idiopathic interstitial pneumonias, and from there, it's idiopathic pulmonary fibrosis. And we go back to our case, 66-year-old man, ex-smoker, that appears to have a bilateral process with chronic shortness of breath, fibrosis, interstitial lung disease. And in the 1970s, this person would have been labeled with the diagnosis of idiopathic pulmonary fibrosis. You have a patient with a syndrome of ILD, which we talked about. You have no explanation. It's idiopathic. Technically, it is idiopathic, but today we recognize that IPF, idiopathic pulmonary fibrosis, is a distinct entity that is much more than just of unknown cause. But this was the approach in the 1970s. And the problem was that people began to realize that some of these patients had different survivals. That some of these patients have different responses to steroids. Some of them improved with steroids, some of them did not. And people began to worry that perhaps we were lumping all kinds of diagnoses into this entity called IPF. And so we were very much helped by histology. Pathologists came and said, why don't we start gathering tissue samples from patients diagnosed with IPF, and let's start looking at the tissue and see if we can determine patterns. And they found a pattern like this one. They found patterns like this one. They found patterns like this one. They found patterns like this one, all of them different. And they realized, oh my God, indeed, we're probably looking at different diseases. That's why these patients look all different. So let's name them. Let's give them a name. And I'm going to make this simple for you to remember, although the history is not quite as I'm explaining it. But I think it's a way for you to remember. They found a very common pattern that was related to areas of heterogeneity. In other words, areas of a lot of fibrosis next to areas that look very normal. And fibroblastic foci, which you're going to see in a larger image later on. This was very common. They saw it very frequently. So they called it usual interstitial pneumonia. Then they saw this pattern, not very specific, very bland, just diffuse inflammation. They called it non-specific interstitial pneumonitis. Not very fancy. Then they saw this pattern, which had significant thickness. They knew that these patients often presented with acute and deadly disease within weeks, and they call this acute interstitial pneumonitis. And they found this pattern, among others, which I'm not going to present today, which you can see here, a lot of black cells, dark cells inside the alveolar spaces. They thought these were dead, desquamating cells into the alveolar space. So they call this desquamative interstitial pneumonitis. It wasn't until years later that we realized that these are activated macrophages. Okay? But clearly the patterns are different. And what that helps us do is that now that we have patterns, we can go back to the clinical arena and see if we can associate patterns with specific clinical presentations and outcomes. And there were two reports. This was the report in the 1970s where they included all this alphabet soup, many others that I've included in there that I'm not going to discuss, and they're no longer part of this list. And then Kassenstein and Myers, who re-reported this in 1998, narrowed down to these entities that I describe here. And later on, there was a consensus statement put together by the national societies that included these into the idiopathic interstitial pneumonias, and they included another one called BOOF in those days, bronchiolitis obliterans and organizing pneumonia, which mainly has accumulations, these tufts of cells and tissues inside the air spaces. And if there's also inflammation in the bronchioli, they call bronchiolitis obliterans. And that was important because in many cases of IPF in the 70s, they were labeled as IPF. What they really had was this. And this is more responsive to steroids. And this may have explained why some of these patients got better. But because many of these are idiopathic, they're included in this entity. So that brings the question of, boy, we really need to have a biopsy. Because these patients may all look alike. They may all look like idiopathic pulmonary fibrosis. But it isn't until I have tissue that I can distinguish between BOOP and IPF and NSIP and so forth. And until then, because the only treatment we had available for these patients was steroids, doctors didn't want to do biopsy. I'm going to give them steroids anyway. And it wasn't until people started doing biopsies that we started gathering more information. And so what we've learned is also that idiopathic interstitial pneumonias requires clinical, radiographic, and pathological correlations, as I told you about the definition. If you have a certain clinical presentation, if you have a certain pattern on CT, with a certain pattern on histology, you can make a certain diagnosis, in this case IPF. But a different clinical presentation, or a different pattern on CT, or a different pattern on histology may reach a different diagnosis. You need all the above to reach an answer. The reason pathology has become important is because when people now can dissociate the histology from the clinical presentation, they can go back and look at outcomes and look at what they found. They found that if you have, this is survival curves of two studies that were done in the 90s, that if you had UIP, the usual interstitial pneumonitis that I presented to you, these patients have a bad survival, about 50% in 3 years. But if you had an SIP, which is another idiopathic interstitial pneumonia, their survival was better. And these people found the same events. So now it becomes really important to have histology, because I really need to know if you have UIP or something else, because that's prognostically important. So that brings us back to IPF, because what they decided to do is that these patients who have this diagnosis of UIP, those are the ones that truly should be labeled as idiopathic pulmonary fibrosis. Everybody else has an idiopathic interstitial pneumonia, but not IPF. Now we have a very distinct entity that is called IPF. So let me talk to you about IPF. So it's within the interstitial diseases. It's the most common of the idiopathic interstitial pneumonias, most frequently that you will see. Certainly the most frequent in our clinics that we're focused on this group of disorders. So let's talk about IPF. It's the most common of the IIPs. As I told you, here's the number of cases, many more throughout the world, mostly in people over 50 years of age. So if you have a young individual, 20 to 30, who comes with a diagnosis of idiopathic pulmonary fibrosis, you might want to question that. Now, there is an entity called familiar IPF, which are cases that have genetic mutations that may be associated with interstitial lung disease. It doesn't have to be IPF at an early age in life. That's a different story, and those are the least common. It's consistent progression with some exacerbations in many cases. This is not reversible. Mortality is over 50% in 3 years. And until recently, there were no FDA-approved drugs for the treatment of IPF. Now we have two, which we'll talk about. They don't cure the disease. They don't reverse the disease. We think they only slow down the progression of the disease, which tells you how much more we have to work on to get more information. I want to spend one slide in talking about mechanisms of action, because there's a lot of people looking in animal models and in tissue samples looking for mechanisms of action. Why? To identify targets for intervention, to see if we can identify targets that can be moved into the clinical arena by developing new drugs. So in general, the lung has, and here's my little drawing of this, you can see the alveolar space that has macrophages. You see the epithelium, and then you have blood vessels here, but then in between you have an interstitium, which usually only has fibroblasts. But if you have too many fibroblasts and too much connective tissue, you may have a fibrotic disorder. Question is why? The most recent idea is that you have some injury to the epithelium. Now, some people are worried about chronic gastric reflux. Some people are worried about viral infections. Any condition that could potentially cause injury to the epithelium in a chronic way in the appropriate host might potentially lead to an interstitial disorder. That's the idea. Not proven entirely yet. But basically, you injure the epithelium and you cause epithelial cell dysfunction. If you kill the entire epithelium, you move into acute lung injury. So this is not about killing the epithelium. This is about making it dysfunctional to the point that it starts producing pro-fibrotic factors, pro-inflammatory factors, oxidant stress. It starts activating cells around it, like immune cells. It starts recruiting immune cells from the bloodstream, and it starts activating fibroblasts in their proliferation and matrix deposition. So you have a chronic state of injury that is trying to heal itself through what we call before disrepair. And this is the cause that people believe it's happening with idiopathic pulmonary fibrosis. Now, the epithelium has become quite interesting because there are a number of mutations that occur in epithelial cells that have been associated with the disease. Mutations in surfactant proteins and mutations in mucin proteins. And also this idea that chronic aspiration may also cause progression of IPF. So these two and more information that I want to describe today have hinted to this idea that the epithelium is really the originator of this condition. Now, I told you before that for all of these conditions, you need to careful analysis of clinical presentation, history of physical exam, a good CT scan, a good pathology, you get to a diagnosis. Now, this is the pathology of IPF. And in fact, I used to have a colleague in pathology that would hold the slide, the histology slide, up to the light and said, this looks like IPF. And he was very good at this. He would just say that mainly IPF is a peripheral disease. You see here? There's peripheral changes superimposed with some areas adjacent that look very normal. So here's another picture where you can see heterogeneity. Again, that word is important. So when you look at pathology report, you want to hear that word. Heterogeneity is some areas that are abnormal, some areas that are not. And then you have these areas here which are accumulations of fibroblasts. And it's thought that the disease is really being driven in those areas of activated fibroblasts and accumulating what's called fibroblastic foci. So if I look at a report from histology that doesn't mention heterogeneity and doesn't mention fibroblastic foci, I worry that maybe we're missing the diagnosis. That's the diagnosis. This is the pattern of usual interstitial pneumonitis. And in the right presentation, in idiopathic, with the right CT scan, with UIP, you make the diagnosis of idiopathic pulmonary fibrosis. Does that make sense? So, again, heterogeneity, positive inflammation. You don't see a lot of inflammatory cells. Honeycombing in some areas that I erased back here, back there. And, of course, fibroblastic foci. Now, here's the classic finding. This is a classic CT that I got from an article from Colby. Some of these tissue samples and cytologies from review articles by Dr. Tom Colby, who is a very well-known expert in this area. And there are 4 characteristics of the classic CT scan for IPF. One is peripheral predominance. I already told you that in the histology of peripheral, look at all the changes here. They're mainly in the periphery of the lung, as opposed to sarcoidosis, for example, where you see more central changes in lymphadenopathy. You also see basilar predominance, but you also see honeycombing. You see this? These little holes here? That's honeycombing. That's scar tissue. That is not reversible. You also see traction bronchiectasis. As you have more fibrosis, you retract that tissue. So the airways are expanded. Not more open. They're just simply more expanded and more dysfunctional. And this is what you see here. Look at this airway. You can follow this airway almost all the way to the pleura. You shouldn't be able to see that. That is traction bronchiectasis. And, of course, no other abnormalities. There's no pleural effusions. There's no big lymph nodes or masses. There's not much emphysema, although you can have both conditions. But in the presence of this is a classic CT scan for idiopathic pulmonary fibrosis. Why is that important? Because I told you that under the right clinical presentation, over 50 years of age, chronic smoker, chronic shortness of breath, with the right CT scan and with histology, I can make the diagnosis. It turns out that if I have a classic CT scan under those conditions, I may not need the histology because the clinical presentation, my physical exam, the physiology, and the imaging studies are enough to make the diagnosis. So if I were to biopsy these people that have this, all of them will look like IPF. So why do the biopsy? So we've gotten to the point that CT scan might even trump your histology because the pattern tells me what the disease is. So let's go back to our patient. And so what I have is a patient with a syndrome of ILD, shortness of breath that is chronic, bilateral changes, histology with inflammation, fibrosis, and physiological derangements. The histology in this case was UIP. Clinical presentation is consistent. I have no explanation. I call it an idiopathic interstitial pneumonia. And of those idiopathic interstitial pneumonia, this patient fits the diagnosis of IPF. And I already told you that if you have IPF, you have a worse prognosis than all the others, and that it's important that I make that diagnosis early on. So how do I manage these people? Well, there's still a lot to be done, but here's what people forget. That if you send me a patient to the clinic, there are a lot of things I can do. Number one is confirm the diagnosis. I can't tell you how many patients I receive with IPF every month that do not have it, and how many patients I receive with the diagnosis that what they have is IPF. So confirming the diagnosis is crucial. It's not that easy. Education and prognosis for them to make decisions. This is a deadly disease. It is progressive. Patient is likely going to succumb to this disorder. They need to understand how to address that. Stop offenders like smoker. Candidate for rehabilitation, which may improve symptoms. It won't improve the pulmonary function test, but it might improve symptoms and how patients feel satisfied with quality of life. Need oxygen. It's been shown that chronic oxygen in patients who are hypoxemic will improve survival. Determine if they're a candidate for lung transplantation. Evaluate for comorbidities like pulmonary hypertension. As you destroy the lung, you destroy vessels. You have pulmonary hypertension that can affect your right heart and ultimately lead to cardiac failure. You can enroll in a clinical trial. And frankly, until last year, that was pretty much all we could do with patients with IPF. We didn't have any treatment specific for them. But now we have agents that are considered antifibrotic agents. And just a few words about this. You may have seen in the New England Journal of Medicine this article that showed that if I gave patients this drug, nintedanib, I may slow down the progression of disease. So what they did is they viewed pulmonary function test. This is a physiological test that I won't describe at this time. And you can see the placebo, how that physiology of the lung gets deteriorated over time, up to 52 weeks. And you can see that with nintedanib, they progress, but at a slower rate. They didn't stay normal. They progress at a slower rate. For the first time in history, there's a drug out there that at the very least had been shown to slow the progression of IPF. And that was huge. Because until now, there were questions on whether we could identify an agent or intervention that could be helpful. This is pirfenidone, a drug that has been on the market a little longer in other countries. Now it's available here as well, but did the same thing. Again, forced vital capacity, a lung function test, over 52 weeks, progression of patients on placebo, progression of places on pirfenidone. But what you need to recognize is when I see these patients that are in front of me, I can't promise them that I have a drug that will get them better or halt the disease. All I can tell them is that the drugs available may slow down the progression of disease. There's a lot more that we need to be doing. Let me discuss other forms of IIP so we get a better sense, and I just have a few cases for you. So now we're going to go back to the idiopathic interstitial pneumonias. Remember that the most common is IPF. So many of these patients, actually, the ones that I'm going to present to you, may show up to your door with a diagnosis of IPF, and it's up to you to define if that's the case or not. Again, remember, clinical presentation, imaging studies, I may need histology. In this case, it could be IPF. In other cases, NSIP. These are the two more common and more difficult to evaluate. Here's case number one. Here's a case of a CT scan. This doesn't show many changes in the upper lungs, but more progression basally. I told you that one of the findings was basal progression. There's some interstitial changes. I don't see a honeycombing here, but there are interstitial changes. 60 years old, so she's over 50 years of age, a female, progressive shortness of breath that is chronic over 4 months. She has a positive ANA, and the pathology showed NSIP. Now, I know that's not IPF for several reasons. Number one, the imaging study is not classic. And number two, the pathology did not show usual interstitial pneumonia. It showed NSIP. This patient has NSIP. Notice that the lab, she has a positive NA. It turns out this woman developed lupus. So as you will see in the next few cases, connective tissue disorders have become one of the most common entities that I see in my clinic because they're very much linked to the development of interstitial lung disease. Let me give you another example. This is how NSIP looks like. Bland, diffuse inflammation. Here's another case, 64 years old, progressive shortness of breath over a number of months. All the serologies were negative. They do an open lung biopsy if they find usual interstitial pneumonitis. And in fact, when you look, he has basal predominance, peripheral changes, traction bronchiectasis in some areas. He has everything consistent with IPF. And in fact, we did label this man with the diagnosis of idiopathic pulmonary fibrosis, only for him to come in several months later, the same year, with classic exacerbation of rheumatoid arthritis symptoms. So he was later labeled as seronegative rheumatoid arthritis with rheumatoid lung. These are not easy presentations, and sometimes you can't make a decision at the time you see the patient for the first time. And the second point that I want to make is, notice that just having UIP doesn't make the diagnosis. Remember what I said from the beginning. You need the clinical presentation, imaging studies, and histology. All together, you make a decision. This is what UIP looks like. So this patient had the classic findings of IPF histologically. He had the UIP pattern, but did not have IPF. Histology is not enough. This is another case, and I'll tell you right now, this is a patient with scleroderma. These are cases that develop severe fibrosis, many cases. Young women, progressive. We don't have great antifibrotic drugs. Cytoxan has been shown to help a bit. It's not a great drug, but it's another one of these connective tissue disorders associated with interstitial lung disease. And so many people are advocating that when you see a connective tissue disease patient, that you immediately move on to pulmonary function tests and CT scan, even without symptoms, to detect patients who have this disorder early on. So here's a table from this article where you can see a number of disorders: polymyositis, rheumatoid arthritis, Sjogren's syndrome, lupus, and look at the histology of all these patients. NSIP, organizing pneumonia, fibrosing bronchiolitis, UIP. The majority of these have NSIP. So these idiopathic interstitial pneumonitis might be associated with connective tissue disorders. They're not quite idiopathic, is my point. And so evaluating for connective tissue disease is important. And that brings a problem. Do I need a biopsy in all these cases? So if I have the right clinical presentation, a syndrome of ILD, I have a CT scan that might suggest interstitial disorders, but I know this patient has lupus or rheumatoid arthritis or scleroderma, do I really need a biopsy? And the answer is that in most cases you don't. That in the setting of a connective tissue disease, you're probably going to assign the interstitial disease process to the connective tissue disorder. So if they have an SIP, UIP, or whatever it is you find in the lung, you're probably going to say, this is related to the connective tissue disorder. So unless you're suspecting a different diagnosis, an infectious disease, for example, or malignancy, having somebody go through a thoracotomy or video-assisted thoracoscopy biopsy is probably not worth it, because you're going to assign that interstitial disorder to the connective tissue disease. Does that make sense? So you won't need pathology in many of those cases. I brought you this case of a patient who was shown as a breath, who, in this case, the CT looks very different than all the CTs that I showed you. There's a lot of opacities here. Many people call this ground glass opacities. But there's also some areas here that are very dark. And so this is what people call the mosaic pattern. Sort of mosaic pattern. Usually that suggests that in some areas there's bronchiolar inflammation. So that these areas are probably hyperinflated. And so it's nice, and many times you've heard us request an inspiratory or expiratory CT scan, because some of these areas can be heightened if I get those phases of respiration. And think about it. So if you have a case with interstitial lung disease, the CT might look very different. But if you have a case where there's obstruction of the very, very small airways, the bronchioles, you will see those areas of obstructive disease on the CT scan. And that's why I brought you how the histology can help you explain the patterns that you see on interstitial lung disease. And this is an example of a patient with bronchiolitis obliterans related to transplantation. This is rejection of the lung. This is a case with BOOP. Currently, there's more interest today in calling chronic organizing pneumonia if you don't have the bronchiolitis. But these are interstitial lung diseases that are affecting the very, very tiny airways. The management of all these diseases is the same. You confirm diagnosis, you treat the disease, a specific connective tissue disorder. If it's rheumatoid arthritis, I treat that. If it's scleroderma, I treat that. But please know that sometimes the lung disease is dissociated from the characteristics of the connective tissue disorder. In other words, they no longer have pain in the morning. They no longer feel bad and the discomfort that the arthritis gives them. And yet the pulmonary condition continues to progress. That's a problem for us because we don't have good antifibrotic drugs. And the two drugs that I mentioned to you have not been evaluated in any other interstitial lung condition. So let's finish with some few fun questions, because I told you that during the evaluation of interstitial disease, you really have to be a detective and ask a lot of questions and find out where they live, and are they farmers, do they have birds, and what are the things you do for a living, what did you do when you were working, were you in construction, what were you exposed to asbestos. All these questions are important, but I have some fun ones. So, where were you born? You might ask yourself, why would I want to ask that? Do you smoke? That's an important one. How old are you? I won't describe some of these. What are your hobbies? What hurts? And does your wife keep you on a leash? I like that one the most. Does your wife keep you on a leash? Okay, so let's discuss just a few of these, if I could. It's not allowing me to go forward or backward. Let me do this something. Here we go. So this is a 45-year-old male with albinism who has dyspnea. It's been progressive for 2-3 years. He has easy bruising. He's been started on prednisone because people don't know exactly what he has. He has oculocutaneous albinism. These patients with problems with albinism also have ocular problems and have nystagmus and so forth. As I mentioned to you, you can document the bruising in the physical exam and some crackles at the bases. And somebody saw this patient and said, where are you from? Where were you born? Turns out this patient was born in Puerto Rico and has the syndrome of Hermansky-Pudlak syndrome, which has 3 presentations. Albinism, albinos, progressive pulmonary fibrosis and many of the mutations of the syndrome, and platelet dysfunction. It's a genetic disorder with a number of genes, each of them called HPS. They're up to 8 to 9 genes already. And they may have bleeding disorders. So you have to know this because you don't want to have an open lung biopsy on this patient. And sometimes they have other conditions like renal failure and colitis. What's interesting about this condition is that the majority of these patients are located in the northwestern part of the island. There's another group with another similar mutation in the central part of the island in the mountains. And this is related to the founding effect that goes back to Spanish colony. There's a founder effect of somebody who came with that mutation and stayed in those particular areas in that mutation. In some of those areas, about one in every 1,600 or 1,200 patients actually have the mutation. Okay? So it's important to identify that, particularly if you go to Puerto Rico on vacation. Next question. How about 27 years old with dyspnea? Dyspnea on exertion, works with computers, pneumothorax on an airplane last year. People just put a chest tube, sent him home. Mild wheezing, evidence of lung biopsy. I will tell you this patient, since I saw him the first time, has had 4 pneumothoraces. Okay? And do you smoke? Turns out, heavy smoker, 2 packs a day. Now, I'm showing you this x-ray of another patient that has the same entity that I mentioned before because she came with the same problem. But what I wanted to present to you, why CT scan is so important. Look at this x-ray. If you look at this x-ray, you probably say it's normal. Maybe there's some hyperlucency up here because I know what I'm expecting here. Maybe it's a little bit hyperinflated, but young people can do that. But look at the CT scan. You probably would never predict such a massive destruction in this patient's lungs by just looking at the imaging studies. What's interesting about this picture is you don't see a lot of fibrosis or interstitial changes. What you see is cystic changes. And there's a whole other set of interstitial diseases characterized by cystic changes in the lung. Lymphangioliomyomatosis in young women, eosinophilic granulomas in young men. In this case, they did an open lung biopsy, and they found that this patient had eosinophilic granuloma, or what's called pulmonary histiocytosis. And what you see here is accumulation of Langerhans cells, histiocytes, involving the very, very small airways. So remember, the lungs are not very small. And in fact, he has obstruction because it's affecting the small airways, just like you would see in chronic bronchitis. So here's an interstitial disorder that doesn't have restriction. If anything, has obstruction, but affects the interstitial and small airways. And what you see here is accumulation of inflammatory cells within the small airways. And when you have special stains for Langerhans cells, you can see them there. Very interesting case. I want to point here that smoking is becoming, or has always been, but is becoming more interesting to us because there's a lot of interstitial and airway disorders that can occur in smoking. And this is the most dramatic case I've seen about this. This is a single patient with at least 6 distinct histological findings. In some areas of the tissue, she had emphysema with destruction of parenchyma and enlargement of the air spaces. In some areas, she had respiratory bronchitis, as you see, inflammation of the respiratory bronchioles. In some areas, she had neuroendocrine cell hyperplasia. And in fact, associated with that, she had some carcinoid syndrome, which is the reason she came to our attention. She had some nodules in the lung. In some areas, she had obliteration of the small airways with connective tissue called obliterative bronchiolitis. And in some areas, bronchiolitis alone. Some of these patients who smoke may even have the squamous interstitial pneumonia, or what people call respiratory bronchiolitis ILD, which is what I told you before about these activated macrophages in there. And this is mainly seen in smokers. If you're not smoking, you won't see this. But consider the number of entities that can be initiated or advanced because of chronic smoke exposure. Think about that. I'm close to the ending here. 60-year-old female with dyspnea. Progressive dyspnea for 2 years, works in the office building, no special hobbies, no clubbing, no crackles, PFT's restriction, desaturation. What are your hobbies? And in fact, this patient, this is not her slide, but this patient had hypersensitivity pneumonitis. It turns out I couldn't find any hobby for her. But she worked in an office building, and downstairs there was a pottery place where they deal with pottery. So in knowing that, we went back and looked at these slides, polarized it with polarized light, and found multiple particles of dust and silica in there. So we think this patient actually had hypersensitivity pneumonitis through the air system. Okay? And sometimes it's important to know some industrial hygienist who can help you with these things. This is not to be confused with sarcoidosis. Remember, these diseases are associated with little or poorly defined granulomas. You can see a granuloma here, no, with multinucleated cells or multiple cells here. This is not the juicy granuloma of a patient with sarcoidosis with bilateral lymph nodes, mediastinal changes, and so forth. Sometimes it's difficult to dissociate the two. I want to finish with this one, which is a 70-year-old male who had cough when running. Fatigue, not eating well, lung crackles on exam. And the question is, does your wife have you on a leash? And here's the CT scan. Does that CT scan look weird to you? This is the CT scan of a dog with interstitial lung disease. And here are the CT scans of dogs and different cats with interstitial lung disease. And here are the histologies of some of those cases. You don't see many normal alveoli in there. And so not only humans can develop these disorders, the domestic animals that share our home and our lives can also somehow develop interstitial lung disease. And we're now in the process to figuring out if these animals can help us better understand human disease. Certainly, it will be easier to treat these animals with new experimental drugs because the veterinary world is also struggling with how to deal with these cases because they're progressive and often they die, the same way the clinicians are dealing with this. Okay? So these are all the animals that have been reported to have interstitial disease, not only humans, but horses, birds, donkeys. The Westies are particularly prone to developing fibrotic lung disease, and cats. So I've talked to you about the interstitial disorders, the idiopathic interstitial pneumonias, IPF. What have we discussed? Well, first of all, that the ILDs are more common and interesting, I would add, than you think. Number two, that you really need detective work, such as the patient that we talked about in an office building that had this pottery farm below her floor. That many are idiopathic, that we don't know what the cause. And if you don't know what the cause, it's difficult to define how to treat them or how to even study them. There are no good animal models to evaluate this condition. Again, there's no good animal models to evaluate this condition. Many people use the bleomycin model. There are over 300 publications of the bleomycin model in the literature, many of them showing improvements with a certain intervention. That is not translated into humans, suggesting that indeed this model is not that great. Treatment options are not many. Many of these patients we treat with immunosuppression, such as the connective tissue disorders. You've heard about prednisone and Imuran, azathioprine, Cytoxan, Celsip. But in the case of IPF, that doesn't work. And of course, these new drugs like nintedanib and pirfenidone might be the beginning, certainly not what we want at the end, but the beginning of developing new antifibrotic drugs that may help us initially slow down progression, but perhaps at the end halt the progression or even reverse it, which would be even more interesting. Let me stop here.